Okay, thank you, Dr. Satyavan Sharma sir. And now it's heating up, and obviously every faculty is somehow taking out time from their busy schedules and coming here for a couple of hours, and then they are going back. So that's the reason our whole schedule may not be the same the way it's printed. The lectures will go up, and that is another reason that tomorrow there is a cyanotic heart disease early in the morning instead of being today. So now, of course, my colleague Dr. Sreenivas will proceed with the structural heart interventions.
Before I go on to just to close this valvular heart disease, the multivalvular disease assessment discussions, generally, as Madam said, I would like to mention that each of you have your own methods. You have various. That's the beauty of having teachers like Dwivedi sir and Sharma sir. Each of us have. So proper history analysis and probably coming on to each point before you go on to the main murmur becomes important. And once you say the MS severe means you might get prolonged MDM, but as Madam was telling, analysis take some points from history, then take some points in the general examination, and then sounds, then murmurs. That way you will get into order, and the examiner will also understand you know the subject well. For example, suppose in the mitral aortic stenosis patient is there. The classical triad of symptoms, generally if it is there, generally you know Braunwald's thing, exertional angina, syncope and breathlessness. Then that means generally patient could have, once the AS becomes significant, it is significant AS, generally symptomatic AS. Then once you come on to the examination, some things are very hard data points. I would request all the seniors to excuse me, just I thought I would also mention. So some things like in the examination, this what mentioned in JVP and all that could be soft, but some things are very hard data. Like if you have a strong parasternal lift, then that means the patient definitely needs to have PAH. And suppose you say apex is down and out and forcefully heaving, that is a hard data, it can't change. Patient should have significant valvular disease to get cardiomegaly. Like that, there are some things which you obviously cannot miss, and you have to properly interpret and you check with your diagnosis. So for example, if you are taking a patient of aortic stenosis, symptoms-wise, then you think of it as more significant. Then probably if you come to vital data examination, probably blood pressures could be systolic decapitation could be there. JVP may not be important unless patient goes to failure. But precardium again could be important, where you could have dilatations. Carotid pulse also is important, slow rising pulse, that is a strong sign that patient could have severe aortic stenosis. Then you have apex beating, slow heaving apex, S4 sometimes could be non-specific in elderly, but sometimes presence could help. And other thing is in second heart sound, though it is looks very difficult to make out, but delayed A2, sometimes paradoxic, again indicates severe aortic stenosis. Then delayed peaking of the murmur also is said to be correlating with severe aortic stenosis, and probably patient going to failure only with AS again could indicate like heart disease being severe. And then those are the things by which you analyze. And each of you could have history. After end of history also, examiner could have ask you what is your history analysis suggests. You should be able to think before you go to the examiner and present your analysis of history. By and large, if patient is presenting with pedal edema or ascites at the first sign, you could think of right heart disease, which is generally not kept isolated disease, but most of the left heart things. Then patient could have breathlessness or palpitations. Long history, short history, these are the things which make out differences between mitral valve and aortic valve. Patient has a long standing history. Generally, it goes with mitral valve disease, and episodic palpitations which started recently could be indicating that patient is going to atrial fibrillation. On the other hand, if patient has only palpitations, then it could point towards more regurgitant lesions. So each of could have your analysis and be ready with some sort of mental makeup and history-wise conclusion. Sometimes if you have a combination, patient could have a combination of symptoms too, but by and large, long-standing histories, generally mitral valve disease, short history, aortic valve disease, combinations could be there. And then patient has a prolonged history of palpitations also, more of regurgitant lesions like mitral regurgitation, aortic regurgitation, rather than stenotic lesions, excluding sometimes of arrhythmias, atrial fibrillation could also have palpitations. Then each of you, if you have remembrance like that for each valvular heart disease, it will help you in analyzing and answering the questions properly, rather than just going on to one particular murmur. I gave example of aortic stenosis. Like that, similarly for each of the diseases, you have 1 point from history, 1 from general exam. Okay, right, thank you. So I think I'll go to structural heart interventions. I was thinking whether to talk only, sorry, only about structural heart interventions, but what I thought is relevant to before you pass the exam, rather than knowing in detail of the procedural details of all the structural heart interventions like TAVR and mitral clip, I thought examiners could ask you with what is latest happening and what are the newer trials coming up. So I thought I would cover up those, and if you're interested, you can see at the end one of the structural heart procedure like TAVR. And I'm extremely happy. Let me express my heartfelt thanks to Dr. Shiva and Pailajani sir and Satyavan Sharma for making Fax Foundation part of this extremely good. I did speak on this podium before regarding the same topic, I think, some time back. Thank you, Shiva, for making Fax Foundation part of this. I'm extremely happy and so much interest, and thanks to Intas. This slide brings best wishes from Apollo Group of Hospitals, where we are trying to network across various Apollos and try to collect some registry data, be it be like PCIs, be it be like TAVR. Combinedly, it is a great strength. But when we are analyzing combinedly about a year back, all Apollos together, we did about 19,600 PCIs. That's a huge data. TAVRs, if we were collecting, we had 500 plus TAVR procedures done across. But the problem is we don't come together, we don't make our own registry data, though we are trying an attempt, and hopefully we should come out with some positive data. It's very important for us to learn from our own things. That's why I keep on telling about it. And back to structural heart disease interventions, as we understand with increasing age, the increasing incidence of aortic stenosis happens, and probably more aged populations are there in our country now. So these numbers will keep increasing. Be it be aortic stenosis, or same thing could happen with even mitral regurgitation as the aging population increases. That's how the increase in interest in these elderly patients with aortic stenosis and mitral regurgitation is coming. Though India, I think KGMC, Dwivedi sir, and GPJ, a lot of other centers, GV Pant, we had strong experience in mitral stenosis. Now this regurgitant disease also is being tackled percutaneously. We should be all thankful to Dr. Martin Leon, who initially in 2001 coined this term of structural heart disease interventions. Basically, we know various types of interventional therapies happen in cath lab, but non-vascular interventions, like coronary and peripheral leaving, it's all being termed as structural heart disease interventions. So increasing elderly people, it's becoming more common, is further likely to increase in future. So what is structural heart disease intervention? Initially, it was termed as a waste basket, including all other things, like apart from the valvular interventions and some things like non-valvular appendage occlusions, all that are also put in this. But it becomes very important for you when you become practice to understand. The beauty of these procedures which brought is, again, it brought all the modalities together, be it be imaging, be it be echo, and be it be interventions in cath lab. Again, unless you have a proper heart team, you can't become perfect in this. And it will also help you to also have a good clinical knowledge, and that's the importance of becoming perfect in this, I think. So this emphasizes the teamwork and image interpretation between the various modalities. It also needs to have some high-end stuff like probably hybrid cath lab if you have, and then probably could change to OTs if required occasionally, though it is less commonly available. So the expertise, the proper infrastructure, the heart team, everything goes a long way in doing the structural heart interventions in a good way in multidisciplinary collaboration. We should all be thankful to this Alan Krieger. I think many of you must be knowing. He's pioneered this TAVR, the first in 2012, and he was a very sick patient who was not suitable for anything. It was transeptal puncture done, but 15 minutes later the patient was improving like this. That's how we got confidence. Never we thought that this becomes more prominent, and but once this was done, TAVR revolution has happened. So it leads to a lot of new iterations, new devices which has come. Why? Because this is almost like an angioplasty. There's a balloon expandable valve, stent-like valve, expands like a balloon, easy to implant and behaves like a surgical processes. and that's how it picked up so well, because it gives clear-cut results. What is TAVR in 2023, we didn't predict before. So there is so much of advancements happened because newer technologies, so many new valves have come in. And the other beauty of this is many of them are done in a minimalistic approach. No general anesthesia, local anesthesia in patients are discharged in 1 to 2 days. So, but how this come is, it was studied very well through partner trials. It was studied in high-risk patients, moderate-risk patients. Now it is actually more than 15,000 patients. But what we need to keep in mind is a proper heart team where all the people are involved, keeping the patient's interest as the top priority. What is good for the patients, we need to do it. With that idea, initial trials were done, and the TAVR 30-day mortality significantly came down. Now it is comparable to surgery, in fact better to surgery. I will take you through. That's how the numbers are significantly going up. Initially surgeons said, the cardiologists tell all this, it may not be true, but this Mac is also one of the cardiac surgeon who's participated in this trial along with Martin Willian. So this partner 1, 2 initial trials were in surgical in unfit patients. Anyway you do TAVR, but later on we went on to moderate risk patients. Now the latest partner 3 was in low risk patients. Why low risk patients is important is most of these patients of aortic stenosis are low risk, and our surgeons do a good job. So you have to be extremely careful, do good results, as good results as surgeon. That's how it was being very carefully planned. So what is this partner 3 trial? If it's important for you, it could be asked in the exams, especially in the Vivas afternoon. At least I did ask a lot of students because I was also personally interested, and what is the latest things happening could be asked. But one thing, once you have come to this stage in discussion, even the clinical case means you are already through, I think. You will be passed. But this could be asked in the post-lunch Vivas also. It's important just for you to take a note of this trial. Partner 3 trial is 1:1 randomized fashion, 1,000 in each group, were randomized to surgery versus TAVR. And then they were followed up initially for a year, then 3 years, then 5 years. So what could have happened? The beauty of it is, you see, surprisingly, this is a death, stroke, and a rehospitalization. What was the aim was to prove it is as good as surgery. This is a primary endpoint which is being studied. This TAVR performed better than surgery, in fact. That's how I think it got into a lot of good reputation, and more centers were adopting it. If you see the total stroke, rehospitalization deaths were less. Even the other thing which is dreadful worried is strokes. That also was significantly less. Disabling strokes were less. In any subgroup analysis, in any type of patient, LV dysfunction, NIHA class, and all these age groups, still TAVR performed better. Obviously, some of these secondary endpoints like bleeding, length of hospitalization stay, if you such things which are more common with surgery you take, then you could anyway TAVR scores over surgery. So in whatever types of complications you see, TAVR had a lesser of problems. So if you see partner 3 trial, it came out, what it said is, surgery is better only in few aspects, like left bundle branch block incidents, mild PVRs are still a problem with our TAVR. That's where I think surgery could score better. Initially we thought valve gradients are better with surgery, but again latest trial showed it is the other way around. Both are equal in this pacemaker requirements, and then coronary obstruction, vascular complications like. But see, the TAVR advantage is better is mortality is less, strokes are less, which are very worrisome to patient, rehospitalizations, kidney injury, new onset of atrial fibrillation, all that is significantly less. So if anybody has to take a decision, saying these are the advantages, these are little advantages, anybody would say which therapy is better? Everybody would prefer TAVR. Obviously, patients also want a less invasive therapy. That's how the partner 3 trial got published in New England Journal of Medicine, after which it became very, very popular and numbers increased significantly. Recently, last week in TCT, Martin Leon presented the 5-year data of partner 3 trial, which is again showed the advantages of TAVR, though were slightly narrowing, but still maintained till 5 years with surgery. The valve size did not matter. All the 3 valve sizes were okay. And deaths, though still less, but the curves were slightly coming together with surgery. CV deaths were less. Another interesting analysis which they did during COVID. During COVID times, then probably TAVR deaths increased compared to surgery. Reasons exactly were predictive. But after COVID, again, then TAVR patients did well. All strokes, though the curves are nearing, still advantage is persisting till 5 years. All the additional endpoints. The only problem which we have is the valve thrombosis, which is slightly more than surgery. But if you see the details of the stroke, and there's not much. But valve thrombosis, most of them were again reversible with increasing anticoagulation. That's a positive thing. But rest of it, most of it again was good. Gradients, initially we thought surgery could be better, but again, TAVR gradients were less. Hemodynamics, valve areas were also not significantly different. And the patient's survival rates are also good. The valvular regurgitation is the only thing, I think, little percentage of mild PVRs are remaining. With coughed valves and sheath valves, that is also becoming less. Quality of life, durability 5 years, no significant difference. So 5-year data concluded saying that both TAVR and surgery are equally good, but for this problem of valve thrombosis, which could be slightly more in TAVR, but again could be treated. And it concluded saying that both are equally good therapies. Then this got published in recent NEJM again. So at the same time, Evolute Medtronic group was doing the trials with other self-expandable valves. This also showed TAVR advantages furthermore compared to balloon expandable valves. Strokes are less and problems are less, clinically implying that these patients were not significantly different, and then TAVR in fact slightly performed better. This is a valve hemodynamics. Supravalvular valves again had a better valve areas. Compared to surgery, these people had less gradients and more valve areas. 4-year data was again presented in recent TCT, showed that the benefits persisted. Then the TAVR patients had better valve hemodynamics, and then all-cause mortality, disabling strokes are also significantly less with TAVR. That's how I think clinical care pathways, the same day, all this, and then clinical outcomes which improved made this TAVR to stay together. So in this 2023, what we now seeing is, we are not bothered which patient is high risk or low risk for surgery, who does poorly with surgery or not, we are not interested. What we are interested in, who will do well with TAVR. Does the patient has any contraindications to TAVR? That's what we need to check. If it's nothing, then we offer TAVR even in low risk patients. That's about aortic valve therapy. I'll touch briefly about 5 minutes and 2 minutes on mitral and tricuspid. Tricuspid valve therapies, again, as you see, mitral valve is a difficult structure compared to aortic. It has various other anatomical targets which could lead to this trouble. So we need to have answers to so many problems which could happen. But predominantly primary degenerative mitral regurgitation or secondary mitral regurgitation. That's what broadly you can divide mitrals into two. Then prognostic importance, we know that if patients has severe mitral regurgitation, their survive are less common. They die faster. So the primary degenerative valve disease, low risk surgical valve repair was done. If it is high risk, when the patients were not suitable, MitraClip was being tried. Then here, if a patient functional ones, generally only repairs or rings were being done in low risk, and high risk we were only giving medical therapy before, a decade before. Now even in other places we are being trying MitraClip. Initially MITRA-FR trial was done, and then co-op trial was also done. One came positive, one came negative. Co-op trial came positive, showing that there is significant reduction in hospitalizations and problems, with all-cause mortality is also significantly less. Then MR severity obviously will decrease when you do a therapy, but MITRA-FFR other trial which came showed that it could be no difference between the both. When you try to see, there is advantage reduction with the clip, unlike this. When they try to analyze what could be the cause, here which patient subsets you are selecting is very important. If you take a patient subgroup in which had a significant mitral regurgitation with not too bad LVs, their patients are likely to improve. This, I think this slide shows you that. MR severity is more, 3 to 4 plus, and then LV size function is not too bad. Those subsets, I think, will benefit by a MitraClip procedure. On the other hand, if you have a hugely dilated cardiomyopathy type of LVs with mild, moderate MRs, they won't benefit. That was taken in the FFR trial, and if a properly taken selected patients, now MitraClip is also replacing the procedure, and gradually going now into the era of surgery, where patients who are being appropriately selected patients with skilled operators, and then now probably this will move further into surgically suitable patients also. But where are we going further? Are we staying only with MitraClip? This is anyway moving, but a lot of new research is happening with the different type of Pascal type of clips which are slightly better compared to the existing MitraClip, are also being planned. annuloplasty reduction procedures. It's not the forum, but we don't have time to discuss in this, but a lot of new research opportunities are going on in discussing and deciding the reductions of various types of other procedures here. So there are new research is going on, but gradually I feel where it is going, rather than annuloplasty reduction procedures and all, which are new caudal procedures which are being tried, gradually it is now going towards more of replacement even in mitral valve. So initially all repair procedures were done. Now I think instead of competing, then probably now what we gradually coming on, this replacement can address all these leaflets, annulus, all these cardiac ventricle problems together. That's how this more research is going on towards newer development of mitral valve replacement therapy also with a less invasive way. So patients initially, when we take, obviously high surgical risk patients are being taken. There are so many new companies which are coming up, newer mitral valve processes which could be implanted initially transapically. Now it has come to transvenous level where they come to about 28 French mitral valve structures. This Apollo TMVR trial is under place, and hopefully they will also do better. Another word about tricuspid valve therapies. In India, I feel it is very relevant to have a therapy for tricuspid valve also, because we do see a lot of patients, especially rheumatic. Whether the same can be extrapolated in rheumatic, we don't know, but we definitely want a solution to patients, because the more the severe the tricuspid valve TR, again the survival will be less. So we need to correct those problems, and we need to save these patients who are otherwise dying with high risk with presence of severe AR. That's how I think newer therapies are also coming up, not only the annuloplasty devices, and but newer tricuspid valve replacement is again happening, even the tricuspid valve area. Tricuspid valve is again a challenge because we are not able to identify properly, image properly the RV function, valves, all that is a challenge. Gradually we are learning more through it. The therapy started long time back, and now we are coming to the stage of clinical usage of these patients. And Sushil Kodali, a friend, recently presented this trial in TCT on the tricuspid valve replacement too. This is a Evoque transcatheter tricuspid valve system. This is 32 French now. Only beauty is it's only venous, so that's how they could do it from femoral vein. And initially first 150 patients, then randomized to 400 patients are being studied. Comparison with medical therapy, what will you get? When you compare with medical therapy, obviously the device reduction of tricuspid valve regurgitation. I'll just finish in a minute, sir. Tricuspid valve regurgitation would be less, and a significant number of patients who had severe TRs grades decreased in 6 months of follow-up. Not only TR grades, but even the functional class improved significantly in these patients. That's how this trial concluded, saying that we could successfully tackle TR also with these new devices, and there will be reduction in tricuspid valve regurgitation too. So what are they bringing in the future? Probably the future is with success of TAVR therapy, bicuspid we are already addressed, but we would address associated concomitant diseases. We also have going to the extent of tackling even asymptomatic AS to moderate AS with heart failure, and high-risk severe AR also. We have data also coming up with percutaneous valve therapies. Cardiologists are smart. Once we get into it, we keep on searching for newer avenues. This early TAVR trial, before the aortic stenosis becomes severe itself in patients of LV dysfunction, this trial being planned. And Martin Lian proposed this new concept of modification of aortic valve before it becomes severe by leaflet modification therapies, which we call it as upstream therapy. But all these should be planned well and do it only with keeping the patient's interest in view. So MRTR front also, as I said, a lot of new things are happening. Toolbox, later combinations of various procedures will come up. But finally, I think mitral valve replacement percutaneously will stand the test of time. Final thoughts before I close my structural heart interventions talk is basically a lot of new things are happening, but mitral valve, tricuspid valve therapy is still in a long way, and aortic replacement, aortic valve therapy, TAVR has already come into regular clinical practice. I think with this I'll stop, and thank you all for patient hearing. More about this was discussed in our recent TCT meeting, and is also there, and next year also it will be there. INTAS will be also helping in this meeting too. And I'm also happy to share, because this Mumbai meeting went very successfully, they've also made me scientific chair for the TCT World Link. Apart from the USA, rest of the World Link program also we are involved, and thankful to all of you for making this Our India meeting successful. Thank you.